Hello and welcome to my YouTube channel and our ongoing conversations about psychiatric disorders. I'm hoping that this conversational way of looking at psychiatric disorders gives you a much more humanistic feel that we're seeing, currently on the internet or other avenues of information. I find my patients often get overwhelmed with those sorts of information. So I try to give you an insider's view, so to speak, because I see patients every day. I hear their concerns, their woes, and their desires and hopes. And I just want to communicate to you that I try to do it in the way that I think it was intended. So, in keeping with that, we were talking in the last video about trauma and how it informs an anxious predisposition. And we talked about treatments, including therapy. And I tried to kind of contain it so that you didn't get overwhelmed with all the complexities of therapy, but you understood the principles. The same approach I want to use for medication. I've talked about how medications specifically act. But in this video, with regard to the treatment of trauma, and I use trauma in the widest sense to inform my treatment of anxiety, okay? So we talked last time about how people tend to overreact in an exaggerated fashion to perceived stimuli that are happening in everyday life, but somehow have enormous significance on an emotional level for them. They may not know why, they may not be able to connect the dots from the past, but certainly their level of reaction seems to be exaggerated to the point that it creates anxiety symptoms, which themselves are very disabling and distressing. So I wanted to talk about the role of medications here. We talked about the SSRIs in the previous videos, and we've talked about the artificial distinction in previous videos between PTSD, OCD, anxiety disorders, and the DSM. From a clinician's point of view, as a doctor, I'm going to treat it all, and I'm going to treat what I see, because that's what gives my patient a holistic sense of moving forward and becoming functional, relieved, and even happy enough to be able to achieve their goals. And I say this very practically because medications do work. I'll repeat, medications do work. You have to find the right one, you have to have the right dose, and you dose it for long enough, and you have to be knowing what symptoms you're targeting. But I know from my experience over the decades that they work, that they provide enormous relief, and one should not shirk them. I understand why there's this fear of that because of information overload, the package inserts, talking about all sorts of horrible side effects. But in reality, most psychiatric medications are tolerated pretty well if they're dosed correctly. So, with that aside, let me talk about their role in treatment of trauma or traumatic responses that lead to anxiety. So, we talked about the SSRIs in the past and how they work. Essentially, what we want to do is dampen down the response. Dampen down the response to things that would ordinarily not make you leap into evasive action or overthink or become distressed, but they are instilled in you because of the past. And so what things like the SSRI or medications like the SSRIs do is that they dampen that response, that hyper-responsivity. And that's important because it makes you able to basically come back down to earth quicker so that you can have a better grasp of reality and make better decisions as a consequence. So patients will tell me that they're less likely to react or overreact in the moment. They're more likely to think twice before they act upon something. They're less likely to avoid and more likely to push through if therapy is combined with medications. And somehow the severity of what they're going through is much less. It's almost like it's become reduced to sort of like a miniature cartoon level where it's become almost like something absurd that they can see right past and it doesn't affect them. That's what you want to make it. You want to miniaturize it. You want to make it such that it doesn't really have the impact that it did when it was this size. And so that's what the medications do. SSRIs are some of them. Some of the medications have sedative effects, so they help you sleep. Some of the SSRIs are more sedating than others. We have medications like Remeron, mirtazapine, which is a serotonin antagonist, which essentially is like a sleeping pill and an antidepressant combined in one. And I oftentimes use that for one-stop shopping for treatment of people who can't fall asleep because they're so anxious, they're ruminating, their body's in overdrive, and it kind of like helps break that cycle. So mirtazapine is one of those medications. For people specifically with trauma disorders diagnosed as PTSD, which is a kind of a different league of anxiety, if you want to call it, I oftentimes will use medications such as prazosin. Now, prazosin is actually known as an antihypertensive to lower your blood pressure, and it works on something called the alpha-1 receptors. Essentially, though, what it does is, again, reduce hyperarousal, the stress hormones, the 0 to 60 reaction to your perceived threat, even if it's exaggerated. And they'll go maybe from 0 to 30, 0 to 10. That doesn't happen overnight. The receptors have to adapt. We've talked about this in previous videos. The receptors have to adapt. That takes time. That takes consistent dosing. And that takes patience on the part of the patient in order to be able to understand the realistic time frames for it to work. But when combined with support, therapy, structure, ongoing efforts not to avoid or feed such behaviors, it can be remarkable in helping a patient unlearn certain trauma-based responses. There are other medications such as clonidine, which act in similar ways, slightly different receptor makeup. There are medications such as mood stabilizers, which essentially, again, dampen the response. Depending on the receptor that they hit, gabapentin, Depakote, even lithium can help with those kind of things. They're not specifically prescribed for trauma, but that's not how clinicians think about prescribing. Clinicians want to go after what we call etiological cause, the kind of biological mechanism that's driving this hyperresponsivity. And so they're going to have to be able to connect the dots as to, is it manifesting as aggression? Is it manifesting as impulsivity? Is it manifesting as terrifying fear? Is it manifesting as avoidance? And so to go after the kind of biological receptor makeup that drives that decision and that behavior. So that is how clinicians think about how to help their patients navigate through this, along with the other interventions. And like I've said before, it's never one thing. You have to combine the totality of these things because the brain is simply that complicated. And we have to use a combination of models: psychological, developmental, biological, historical. And you can see how complicated it is, how challenging it is, but how encouraging it is when you see patients respond to the totality of all these things brought together. So I hope that was helpful, and we will continue to talk in other videos of how we approach the mood disorders in similar ways, depressive disorders, bipolar disorders, and eventually other disorders too. As always, stay safe and have a great day.